Yeah, I think we'll get started. So welcome to Pediatric Grand Rounds. I'm really excited today to introduce Dr. Suni Kaiser, who's going to give our presentation. Dr. Kaiser has done just an exceptionally productive career here at UCSF. She originally trained at Hopkins and Wash U, and then joined UCSF for her pediatric residency, and then joined the faculty and left for a short period of time to complete a pediatric hospital medicine fellowship at Sick Kids in Toronto, as well as a master's in clinical epidemiology and healthcare research. And then she came back to UCSF, and we were so fortunate that she came back to be part of our department. Dr. Kaiser is one of the very few hospitalists, pediatric hospitalists in the country who has NIH R-level funding. She's a national leader, both at the AAP and in other pediatric research settings. Her research is focused on improving care quality and health outcomes for hospitalized children. She's received numerous honors, including the AAP's National Pediatric Hospital Medicine Quality and Safety Award, as well as the UCSF Flag Mentorship Award. And so it's a great pleasure to introduce Dr. Kaiser to give our grand rounds today.
Thank you so much, Dr. Hirsch, for that introduction. Let me just share my slides here. Okay, perfect. Well, today I will be speaking about using implementation science to improve pediatric hospital care. My focus is on using implementation science specifically in the realm of pediatric hospital medicine, because that's where I work and is the setting that I've trained in. But these concepts and tools actually come from the adult world and are very broadly applicable across medicine and even other fields. So I really encourage all of you to think about how to use these concepts and methods in whatever work you do to enhance their reach, the reach and impact of your careers and your projects. So I have no conflicts of interest to disclose. Broadly, the objectives for sort of the next 40 minutes or so are first to understand the goals and methods of implementation science, to review some examples of large-scale interventions that have been done to improve hospital care quality, and then lastly, to identify some future focus areas for improving care and outcomes for hospitalized children. So I want to begin by just talking a little bit about the problem of getting evidence into practice, which is what implementation science focuses on. So most of you are familiar with this sort of roadmap of the stages of the research and discovery process. So T1 research is really our classic kind of bench or lab-based research where promising interventions are starting to be translated to potential kind of use in humans and our patients. And then in the T2 realm, this is really kind of our classic clinical trials establishing the safety and effectiveness of these interventions. Now, the work in this realm classically culminates in writing a paper in a journal, maybe presenting to a live audience at a conference. And that's where most basic and clinical scientists' work, unfortunately, kind of ends. And we often assume that with those tools, with journals and conferences, that really critical information of how to help patients reaches the bedside consistently and broadly. But we know now through research that's been done over the last 20 or 30 years by a number of people that unfortunately it takes up to a couple of decades for that best evidence to really be put into practice consistently in the use and used in patient care. So T3 research is really about the dissemination of our best evidence to the right people and the implementation of it into clinical workflows to actually reach patients. And then T4 is really about measuring the population health level outcomes we achieve as a health system. The T3 and T4 realms are also known as kind of health services research. And, unfortunately, up until now, the NIH and other funders around the world have really heavily funded T1 and T2 research, which is absolutely mission critical to, advancing how we care for patients. But they've really left little funding for this kind of T3 and T4 work, perhaps really less than 10% of most national research budgets. And that's increased over time, but it's left, again, these long lags and gaps between our best therapies and diagnostic tests and our best knowledge reaching all of our patients consistently and equitably. And so I mentioned that these T3 and T4 realms are also kind of broadly known as health services research. The bubble on the left here is kind of that T3 dissemination and implementation work I was talking about. So in dissemination research, we think about how to best disseminate information to the right people effectively. And in implementation, we think about how to support the behavior change that is needed for clinicians to use this in real time in the care they provide. I love this field because it really draws broadly across from theories and tools across the social sciences. So we use psychological behavior change theories. We use sociologic theories of how organizations evolve and change over time. Things like behavioral economics. So there's a lot of tools in the tool belt of this T3 research. But what I'll present to you today are some examples of QI research. So many of you may be familiar with the fact that QI comes from the corporate world, from industries that were trying to create high reliability kind of workflows. And QI inherently is really designed to solve a local problem. So most of the QI that's done in health systems is really focused on one clinic or one hospital identifying a problem, thinking about their context and their people, and testing out potential solutions to solve that problem. It's meant to be quick, nimble, and really, again, context specific. QI research, on the other hand, is meant to think about the fundamental tools used in QI and test whether they can be more broadly used, whether they're generalizable to broader settings and populations. And so we test things using many of the same kind of tools you would use in T1 or T2 research, like a trial with a placebo control. Again, I'll give you some examples of that kind of in the next section. And then on the right side, you see what we would consider kind of T4 or population health research. And this is another really big realm of health services research where we really try to measure the health and equity and access we're achieving as a healthcare system. And even potentially compare that to others, as well as think about how policy affects those outcomes. That is classically done with more of an observational design more commonly. And again, broadly, these types of research that I'm describing are under the umbrella of health services research. So I took a few minutes here to describe that again, just to familiarize people with the goals and the methods, because they're perhaps less familiar than those more classic methods in bench and clinical research. Some of the kind of early pioneers in health services research based out of Dartmouth created a series of maps called the Dartmouth Atlas. And they really highlighted this problem that implementation science tries to tackle of closing the gap between evidence and practice. What these maps show is the high variability in the care patients receive nationally, depending just on where they are. So on the left side is a map that shows 5-fold variation in rates of adult elderly diabetic patients getting yearly hemoglobin A1C screening, which we know is really fundamental to better diabetes control and preventing all the complications of diabetes. So the blue areas are much, much lower in terms of their screening rates, down to even 20 or 30%, where the dark green are sort of 90 to 100% screening rates. On the right, we see some of the consequences of that variability in clinicians adhering and carrying out those recommendations. Because on the right is a map of readmissions to the hospital within 30 days for another severe illness. And the red areas show places where people have twice the risk of getting readmitted to the hospital with severe illness. So again, these are just illustrations at that population health level of the unfortunate gaps in sort of putting evidence into practice and achieving sort of what we can as a health system for everybody we care for. So I'm going to move into giving you all a few examples of work that our research group and others have done around improving hospital care quality. But again, I want to encourage you to think about how these tools and methods might be applied across other fields and your work as well. To give some background, I just want to kind of seat a little bit where hospital care lies in the realm of, overall pediatric health care. So most children, fortunately, are never hospitalized outside of their birth. Hospitalization is a rare, but as we know, really stressful and even devastating event for patients and families. It's also by far the costliest sort of healthcare encounter that children undergo. So although children are seen in the ambulatory setting sometimes multiple times a year and maybe never in the hospital after their birth, hospital care represents nearly a third of overall pediatric healthcare spending. And so it's hospital care in adults and kids has always been a focus of quality and safety efforts. To give some background as well on some of the topics I'll show QI work has been done in, these are kind of the top things we care for in the hospital setting. So I mentioned that birth is by far the most common reason for pediatric hospitalizations. But after that, pretty consistently, the most common reasons kids are in the hospital are for different respiratory illnesses like bronchiolitis, pneumonia, and asthma. Mood disorders, including major depressive disorder, is another very common reason that's actually been consistently rising up the ranks over the last decade. And then you can see on the right some other reasons like cellulitis, UTI, hyperbilirubinemia, and these are all things those of you who have done your hospital rotations have commonly seen. So with this in mind, our research group has focused on asthma care over the last sort of 4 to 5 years. So I'll present some data on those projects. So Dr. Hirsch mentioned that I was in Toronto briefly for my pediatric hospital medicine fellowship. And I had a co-fellow there who was also from the States, from Children's Colorado. And there was a morning we woke up sort of post-call and, kind of debriefing about the night. And I mentioned that I had an asthmatic child whose parents, really wanted to go home the next day. They had a lot of financial strain and needed to get back to work. So I set, alarms and woke up kind of multiple times through the night to check on them, to wean his albuterol so that they could go home first thing in the morning. And I was telling her about it and she said, well, Suni, in Colorado, we just have these pathways, these protocols, and the nurses, when they go in for doing vital signs anyway, they just wean all their treatment and then I write a discharge order in the morning. And I was like, wait a second, I'm at UCSF, we're at Sick Kids. I was at, Children's St. Louis before. None of those places have these pathways. Like, why are these efforts so siloed? Why do I not know about them? And I started to look into the evidence behind them. And at the time, this is back, maybe around 2014, 2015, there were 3 or 4 really, high profile children's hospitals that had published about their experience implementing these kind of pathways. And not only were they getting kids home faster, but given that, there was a little visual document people were referencing, it had other reminders in it of things that we should and shouldn't be doing as well. And so those kids were getting less antibiotics, getting less x-rays, getting their steroids more quickly. So all kinds of benefits to their quality of care. But it still wasn't clear if these kind of tools could be used kind of outside of these specialized academic children's hospital type centers. And simultaneously, kind of around the same time, Dr. Joanna Lionar, also at Dartmouth, put out a paper just showing a little bit about where kids are taken care of in terms of hospital care in the US. And it turned out that, less than a third were cared for in kind of our academic freestanding children's hospitals. And the vast majority, when they were hospitalized, especially with common conditions like asthma, were being cared for in community hospital settings or maybe more specialized children's hospitals, but that were within larger adult centers, kind of nested children's hospitals, we call them. So that sort of begged the question, well, these pathways are great. They can really help kids and families, but can they really be used in all these diverse settings, in little rural hospitals, in suburban settings that aren't attached to big academic centers? Do they have the kind of bandwidth and infrastructure and ability to implement these tools? So I wrote a grant at that time during sort of my fellowship and master's, started the process. And this was a career development award grant, which it's great if, people are aware about. It's a 5-year grant from NIH, or I got it from AHRQ, which is the Agency for Healthcare Research and Quality. It's really focused on early career scientists and developing their ability to build a research program, and mainly supported my time. It didn't have a big research budget, but gave me the time to conduct a series of studies, which are outlined here. So given this knowledge that I've explained, what I sought out to do was, in a first study, identify children's hospitals, identify the ones that were most successful in improving care quality by implementing pathways. My next study involved then going into these really successful sites and trying to understand kind of all the nitty-gritty and the strategies they used to be successful. And then the third study was going to be testing both the feasibility and the effectiveness of implementing pathways in both children's and community hospital settings to understand whether these tools were broadly generalizable, and we could support all different kinds of sites in doing this work. So in that first study, we wound up surveying around 120 hospitals around the country, asking whether they had asthma pathways, and if so, when they implemented them. We subsequently used a large administrative database to say, okay, well, how effective was your pathway implementation effort? If we look at how care quality and length of stay, other outcomes for kids looked like before you put in the pathways and after, was there a significant change? And when looking across the whole group of hospitals, we thankfully saw the same overall conclusion that those single center studies showed us prior, which was that there was increased use of recommended medications, decreased use of unnecessary things like antibiotics and asthma, and decreases in length of stay and associated costs for families and the healthcare system when pathways were implemented. But what this graph on the left shows you is that those effects were really variable for one hospital versus the next. So Many had those quality improvements, but others, despite spending time and energy on implementation, saw no change at all. And so it was important to then understand exactly kind of, again, the details and strategies that those successful sites used. So we then went to using qualitative methods. And you'll see a lot of familiar names kind of cited on these papers here. Arpi Bekmesian and Michael Cabana helped with this work. And we interviewed folks at those really high performing hospitals and also some of the QI team members at the lower performing hospitals that saw no change to see what was different. What was different about what some sites that were successful did versus others. And we found these 5 core principles around pathway implementation were really consistently used at high performing sites. So they used quality improvement methods like plan, do, study, act cycles, and a really data-driven approach where they were looking at their outcomes month to month to really track how they were doing and share that with others. They had really diverse multidisciplinary teams that engaged all the people involved in pediatric respiratory illness care, like respiratory therapists, nurses, pharmacists, and everyone got together and committed to shared goals around what they wanted to achieve with pathway implementation. They had engaged hospital leaders for needed resources and prioritization of this work. And they built reminders as order sets or other types of decision support into their electronic medical records so that clinicians would see this in their workflow day to day anytime they were kind of admitting or caring for a child with asthma. So with this knowledge in hand that pathways could be effective in a broad group of hospitals with potentially these strategies put into play to implement them, we partnered with the American Academy of Pediatrics VIP network. So that's a network focused on quality and value improvement in the hospital setting for kids. We conducted a randomized trial, and this trial was a stepped wedge, which meant that hospitals weren't randomized whether to get this or not, but rather what point in time they would get it. So we still had control data to compare to know whether the intervention made a difference or not. In total, with the AAP support, we recruited 85 hospitals and 82 emergency departments around the country into this study. And we used all the strategies we'd learned from this qualitative work. So we supported them in using QI methods and data and supporting their implementation efforts. We encouraged and supported them in gathering together multidisciplinary teams. We provided educational seminars and guided them through the process of modifying their electronic health records to embed those little reminders about the evidence-based practices we wanted to promote. All in all, over the course of the study, there were nearly 20,000 kids in emergency departments around the country and 12,000 hospitalized kids included in our analysis. And I'll go through a series of slides here that outline what the effects were of this work. I'll orient folks to this because it shows kind of change over time and how to interpret these graphs. So the data points on the left side of this graph are their performance before we started implementing these pathways, and the orange line shows the overall trend before our intervention. The orange dashed line shows then what would have been expected to happen in terms of care quality had we not done any kind of intervention. And then the dots on the right side and the blue trend line of those shows what actually happened after we implemented pathways. So this is one of the first outcomes we looked at in the emergency room was kids getting triaged as far as their clinical severity with a respiratory score right at arrival at ED triage. And what we found that was that, had we not implemented this intervention, that we would have expected about 83% of asthmatic kids in the ED to have that assessment right at triage, but we had a significant bump with our intervention up to 95%. We also wanted to encourage more timely, quick administration of systemic corticosteroids, which has been shown to decrease ED length of stay and risk of admission. And with this as well, we saw a significant bump from an expected 49% of kids up to 53% of kids getting steroids within an hour. And then we saw a slight decrease in the risk of hospital admission from an expected 21 to 20%. On the inpatient side, we were encouraging early and more frequent use of metered dose inhalers in the inpatient setting because this creates more opportunity for teaching around appropriate MDI administration, more self-efficacy amongst kids and families in doing this, and overall better chronic asthma control. So for this measure, we found that we would have expected about 49% of kids to have had early MDI early and throughout the course of the hospitalization, and this bumped up to 74% with the intervention. And then we wanted to refer any caretakers who smoke tobacco to tobacco cessation resources, since that is a trigger for asthma exacerbations and worse chronic asthma symptoms. So for this, we would have expected about 27% of eligible caretakers to be referred based on prior trends, and this bumped up to 65%. We found, thankfully, that these bumps in overall compliance with evidence-based practices were significant across all types of hospital and ER settings, with community hospitals benefiting significantly more even than children's hospitals, non-teaching emergency rooms and hospitals having bigger bumps in compliance than teaching sites, and smaller ERs having even bigger bumps than the others. But you can see all these numbers are positive, showing, everybody moved in the right direction with the intervention, which was great as well. Nisha Gupta, one of our former PHM fellows, helped with this work. And Mansi Desai and Kate Caldwell were great leaders of this work locally in two of our UCSF affiliate hospitals, UCSF Fresno, which was formerly a Community Regional Medical Center, and also at Washington Hospital in Fremont. So these are results from their local work leading this project, again, in the Bay Area. You can see that there were increases in timely steroid administration from 32 to 57%, from 62 to 75% in the ER. There were decreases in the use of unnecessary chest x-rays and radiation exposure for kids from 44 down to 29%, and decreases in ED length of stay. On the inpatient side, there were increases in secondhand tobacco screening and also decreases in unnecessary antibiotic prescriptions at discharge. So I'll go on to just talk more briefly about a couple of examples of kind of large scale national QI work that the VIP network has done. The BQIP study was focused on bronchiolitis. This involved about 20 hospitals. And as many of you are familiar, in bronchiolitis, it's really about doing less and avoiding unnecessary treatments or overuse. So in this project, the boxes here have a center line, which represents the median decrease in these non-recommended treatments over the course of the project. And you can see that that ranged from, decreases of 25 to 65% in unnecessary use of bronchodilators, steroids, and chest x-rays in kids with bronchiolitis. This is an example from a pneumonia study called ICAP. This one focused on really improving antibiotic stewardship to decrease kind of unnecessary antibiotic side effects in kids, as well as community level antibiotic resistance. So here we wanted to see increases in stewardship compliance. And you can see, looking at those same kind of center lines in the boxes, that there were increases of kind of 10 to 30% at the various points in the course from the ED to hospital discharge. This graph shows compliance with use of narrow spectrum antibiotics, but the project also tried to cut down on use of macrolide antibiotics, for which the changes were similar. The VIP network did another national project more recently called SOFI, and this was focused on improving use of isotonic IV fluids for maintenance fluids in kids, so as to decrease the inherent risks around hypotonic fluid use. The left graph, which is a bit complicated, is the national data from the project, which showed an overall bump of around 10% in complying with isotonic fluid use. And then the right side shows some great work done by Matt Nordstrom in our division here at UCSF at Mission Bay, where he was able to oversee education and EHR changes to increase the compliance with isotonic fluid use from 63% of patient days up to 95%. So again, those are examples of QI research and QI at work in trying to, again, improve overall clinician compliance with these evidence-based practices to improve care quality. But I'm sure you all are aware of examples of this in your own fields, and hospital medicine has been a real leader in quality and safety work, and sort of taking it to scale. So that I posit those examples again as ideas of things you might take into your own work and other fields as well. But in this last section, I wanted to talk a little bit about areas of future focus for improving pediatric hospital care. So to do that, we have to set the stage a little bit about pediatric hospital medicine, because it's a very young field. So it was only in 2003 that we had our first national conference, and then the PRISE network, or Pediatric Research and Inpatient Settings Network, was founded to promote hospital medicine research. And just in 2008 was when that BIP network started that I mentioned and showed a lot of the QI work from. And then just a few years ago, we were certified as a subspecialty and started our first board exams and started certifying our fellowships. And for this young field, the main focus, given the sort of complexity of hospital care and the interest and capacity of our workforce, has been in the realms of quality and safety. We are just, starting to build some infrastructure around clinical research and discovery. So what I would posit are kind of our big areas of focus for the future are, first, advancing health equity by better leveraging some of the quality and safety infrastructure that hospitals have invested in, and also leveraging hospital resources to reach outside of hospital walls to advance health equity agendas. To get sort of more juice for the squeeze, we've invested a lot into building hospital quality and safety infrastructure, but we're still limited in kind of the efficiency of these efforts and their sustainability over time. And then lastly, as I mentioned, a big area of continued need for capacity and infrastructure development is in PHM clinical research. So I imagine that these agendas, again, are shared across many fields, but I'll talk a little bit about how our program in concert with these national organizations is trying to advance these agendas within PHM, and I encourage you to think about how some of the same principles might be used more broadly. So first, in terms, I'll focus on advancing health equity. So quality improvement at its core has an underlying assumption that as you standardize care, that the effect will be a reduction in disparities. But in fact, this cause and effect kind of relationship is more complicated than that. So if your quality improvement intervention or work disproportionately benefits an underserved group, then it will lead to reductions in disparities. However, if the intervention affects all groups equally, then any pre-existing disparities will just be maintained. And if unintentionally your QI intervention disproportionately benefits the majority group, then unfortunately you could worsen pre-existing disparities. Now, the pediatric realm is really nascent in understanding and examining these effects, as is the adult world, to be honest. But in the adult world, which is published more on the effects of QI on healthcare and health disparities, we find examples of all three of these outcomes. I think a notable example of worsening disparities are there's been a couple of states that have done adult collaboratives around improving the timeliness of sepsis care in emergency rooms. But when they put out the resources to participate in these collaboratives, it tended to be that better resourced hospitals that served wealthier populations participated more often, and safety net hospitals just didn't have the bandwidth to do so. So then when they looked at the state level at how, Medicaid collaboratives, QI collaboratives impacted disparities, they actually widened disparities in care and outcomes for adult sepsis management. So again, this is very important, and there's been a broad call for QI work to keep an eye on, at the very least, what its impacts are on health disparities. With that in mind, one of our really talented fellows, Sarah Schechter, did this work where after our PIPA asthma intervention was complete, she analyzed its effects on disparities. And we found that before, the intervention was designed again as a classic QI intervention without a particular goal around health disparities a priori as we launched it. And we found that before the intervention was implemented, that patients with public insurance, which we used as a marker for lower socioeconomic status and private insurance, that kids with public insurance were actually more likely to receive evidence-based care. So they were getting their systemic corticosteroids more quickly in the ER, they were getting less chest x-rays, and they were more often getting screened for secondhand tobacco smoke exposure. But despite that, the health outcomes for children on public insurance were worse. They had higher rates of hospital admission from the ER, longer lengths of hospital stay, and higher risk of being readmitted to the hospital or having an ER revisit within 30 days. And ultimately, when we tested whether the intervention affected those disparities, it did not affect the differences in evidence-based care or the health outcomes that we achieved in terms of disparities in those outcomes. And we found, as we did this analysis and did some literature search on the effects of pediatric QI and disparities, there were very few, if any, papers we could find that had examined this. So Sarah has gone on over the last year to do a systematic review of pediatric QI interventions effects on disparities, along with two of our really great medical students, Adria Bowles and Lucky Ding. And in this systematic review, we found that less than 1% of pediatric QI studies that are published actually report on or examine effects on disparities. And those that did, the majority of the time, nearly 80%, did find disparities by either race or socioeconomic status or primary language at baseline before the intervention. The good news was, though, that of those that measured and had some sort of focus on disparity, 80% led to reductions in those disparities. So there's really immense potential again for QI to be better leveraged to improve disparities. So with those studies in mind, I would posit that these are really the future areas of focus for better leveraging QI to advance health equity. One really fundamental thing is improving our measurement and reporting of QI's effects on health disparities. So we're now doing a multi-center trial with about 45 hospitals across the country. In that, right from the start, we're going to be measuring effects on primary language, SES, and race and ethnicity-based disparities. We're also partnering with the Children's Hospital Association and BIP, the AAP's network, in thinking about how to collectively advance the infrastructure we have in quality and safety work for measuring and reporting on health disparities. The next step will really be to try to better leverage QI to achieve both goals, quality and better health equity. And that will surely require broadening the partners we engage in QI work to include families and community partners, and using some qualitative approaches to ask why, when we do see disparities, what those drivers might be, and come up with creative interventions that we can test to help close those gaps. Another big realm that hospitals are engaging in to try to reduce health disparities are using the hospital or ED encounter to screen for and intervene on social needs. This is work that Matt Pantel in our division is leading locally, and the Centers for Medicare and Medicaid are really mapping out and developing and testing tools and funding models to help encourage this work. And ultimately, another sort of layer of those efforts will be forging more robust partnerships between healthcare systems and the community partners that are already trying to address social needs and social determinants of health. The Centers for Medicare and Medicaid are also working in the space, again, trying to encourage this from a policy and funding standpoint, and mapping out for hospitals exactly what the steps are in doing this. The next area, sort of a future focus for PHM, I would posit, is to improve the efficiency and the sustainability of the efforts we engage in, of the QI efforts we engage in. So I mentioned we are launching a multi-center trial currently. It has about 45 hospitals enrolled. And the premise of this study is that there was a QI intervention, sort of a model for how to do QI that was tested at Seattle Children's Hospital. And it really involved kind of tackling more at once, up to 10 kind of common PHM conditions per year through standardized pathways and workflows. And so we're trying to, again, ask this question: can what's done in a high resource academic sort of pediatric focus setting be done more broadly? And the hospitals that we will be testing out this kind of multi-condition QI intervention on represent that broader sample of hospitals all over the country that are more community-based. With this study, we'll definitely, focus on determining the effectiveness of the intervention, but we'll also try to understand how to optimize implementation, again, understand its effects on healthcare and health disparities, how to optimize clinical decision support tools, and what the time costs of this work are. And then it is yet unclear, with most QI efforts, there's a lot of time and energy and resources sort of invested up front over a span of maybe 6 to 12 months. But we know from the larger kind of QI literature that when we measure outcomes on a longer time frame of 2 to 5 years, that unfortunately the majority of those quality gains slip over time, kind of wasting the time and resource investment that's done up front. Sarah Schechter again helped lead this analysis of sustainability after the PIPA intervention. So we recruited a subset of hospitals to collect data for an additional year after that first more intensive year around implementation. And we found concerning declines in several measures, like the one here, which had to do around referral to smoking cessation resources. And again, this is a common story as other priorities come along and you don't have systems in place to sort of maintain sustainability, that these benefits might slip over time. And so what we did was we found that just like kind of early on, the graph that I showed you illustrated that at the hospital level, this was very variable. We found there were many hospitals that were able to sustain over a two plus year period. And we went in and did qualitative work trying to understand what strategies they used to promote sustainability. And a postbac student, Shravya Jaladanki, led this work. And we found that at the hospitals that did sustain their quality gains, there were two core strategies that they consistently used. One was building electronic order sets that continued long-term to remind clinicians of these evidence-based practices, and that were built in ways that made their workflow easier, quicker, and automated that reminder. We also found that those hospitals had long-term local champions in place that continued to do things like educational efforts for new staff and troubleshoot new problems that came up. So we do plan and have proposals written to test these strategies around sustainability in the future, again, using kind of multi-center trial approaches. And then the last point I'll touch on in pediatric hospital medicine for future directions is promoting discovery. So I mentioned that we're a new field, which to date has primarily focused on quality and safety, as well as medical education in terms of scholarly work. But overall, across pediatrics, we find that the rate of publication of randomized controlled trials, kind of our gold standard for changing the way we care for kids and testing new approaches, is low and stagnant. So over the last 2 decades, the rate of publication of adult RCTs that are changing practice has consistently increased year over year, but has really stayed the same in pediatrics and is largely driven by pediatric oncology and critical care subspecialties. But in PHM, this has not been growing, and looking over the last year, less than 1% of published studies were randomized controlled trials trying to kind of advance the way we do things. So we need to take some critical next steps in advancing our ability to do clinical discovery. And I've partnered with Dr. Eric Kuhn at Intermountain Healthcare in a grant also funded by AHRQ that will launch a conference this year that brings together clinicians, researchers, patients and families, funders, and health equity experts in developing a prioritized national PHM research agenda that's really rooted in that data on the most common conditions we care for. The other thing we'll need to do is employ some of the new innovative methods and technologies that can make trials more feasible. So some of the things we're thinking about testing with this group are having sort of smaller samples of patients that need to be recruited from each site to make it more feasible, but spread that recruitment burden over a larger number of sites. And then use new methods like single IRB, which can streamline the IRB process, and electronic consent, which can make consent faster, designing trials that are very real world, real condition focused, that seek to understand, again, both effectiveness and implementation, so that once we know something is effective, we already have some knowledge of how to put it into practice quickly. So just to close, I want to thank you all for your time and attention. The overall points I was trying to make here, which I hope you take away, are that implementation science is an important tool for taking our discoveries that final mile to actually consistently reach and improve the health of our patients. It's something that, dissemination and implementation is something even kind of people doing T1 and T2 research should think about, again, to really improve the impact of their efforts. That pediatric hospital medicine is a young field that's made progress in the areas of quality, safety, and value in really large scale demonstrations like the ones that I highlighted here. But important future areas of work for our field include leveraging hospital infrastructure and resources to reduce health disparities, improving the efficiency and sustainability of the time-intensive QI efforts we engage in, and increasing overall the evidence base for how to improve care and outcomes for hospitalized children. So I thank you again, and I'll open it up for questions. And I think there might be some in the Q&A and or chat. Maybe I see one. Oh no, I just see a prompt from Cherise to enter your question. So I'll just hang here. And again, thank you all. Anyone that needs to hop off, please go ahead and do so. But if you have questions, please enter them and I'm happy to answer.
Any questions from the audience? If not, I want to thank you again, Suni. That was really, really great work that you presented and really impactful. And again, congratulate you for your exceptional productivity, both here and in the field of pediatric hospital medicine more broadly. We're honored to have you as a part of our department. I want to thank everybody for participating today and wish you a good rest of your week. Take care.